So these are the various examples of bradycardia. So the first one is typical sinus bradycardia. You have a one-to-one relationship between the P and the QRS. The second one, we see a relatively prolonging P-QRS relationship. We see the AV delays getting increased until there's a drop in a beat. The third ECG is actually showing there's no relationship between the P waves and the QRS. So the P waves are at a different rate and the QRS is at a different rate. This is most likely a complete heart block. We see the above ECG. This is showing a P-QRS relationship is constant, but suddenly there is a block. So this is a Mobitz type 2 block. This is irregular heart rate will be there in these cases. And the below one is an AF with a slow ventricular rate. So this is what I was talking about when we were classifying bradyarrhythmias. So again, like I said, the management is based upon atropine. I mean, if we detect that the patient is bradycardic and is having symptoms, then if we do not notice that there is a satisfactory response, we may give an infusion of isoprylene or adrenaline and also repeat atropine. Also, it's worthwhile to consider transcutaneous pacing at this point of time. The other drugs that can be used to manage bradycardia are aminophylline, dopamine and glucagon or glycopyrrolate. So, but then these are sort of stopgap measures before you are able to initiate a transvenous pacing which is more reliable. So in the meanwhile, you can try some of these strategies to improve the heart rate. Transcutaneous pacing can be done without the need for any catheterization. So it's important to know how these machines work, how you stick on the paddles. So indications of pacing, of course, any kind of symptomatic bradycardia which is non-responsive to atropine is indication for pacing, especially in association with inferior wall MI, or in fact more relevant with anterior wall MI. If it is there, you have to definitely pace these patients. Inferior wall MI, they may require a temporary pacing at least till you are reperfused. And then sometimes when we have to suppress some arrhythmias, there are some brady dependent arrhythmias are there. So we are not able to suppress them because any antiarrhythmic drug will worsen the bradycardia. So you may want to pace them, and then you give those antiarrhythmic drugs. Pre-operatively and in certain operative conditions where they feel that the AV node will be affected, the surgeons would put on these prophylactic pacing wires. So in some cases where we are taking up a patient with say some history of bradycardia or some doubtful conduction system, we may want to put them on TPI before we take them for surgery. So these are the indications for pacing in general. So like I was talking about the transcutaneous pacing, it's we have these two patch positions, the anteroposterior and the anterior and anterolateral. So these are the the controls. We have to make sure the one thing that happens is when you stick on, you start the pacer. It's not always necessary that it will pace or capture. You have to check the femoral pulse to make sure that it has paced. You may want to sedate the patient also because it's quite painful to the patient. So these two things we have to keep in mind. The transvenous pacing, of course, with the balloon tip catheters, it should be possible to pace through the jugular without the need for fluoroscopy. The last one that this picture is actually a transesophageal electrode. I mean, transesophageal pacing is used in children. So we don't have much experience with that. We need a different stimulator for that. So that's a transesophageal electrode. So then we move on to the tachyarrhythmias, which are more dramatic that way. So we differentiate them on the basis of a wide QRS tachycardia or a narrow QRS tachycardia. The narrow QRS indicates that the depolarization of the ventricles is happening through the His-Purkinje system. So the origin of the tachycardia is in the supraventricular portion, that is around the atria or the AV node. So they are also labeled as a supraventricular tachycardia. Again, they are classified into regular or irregular. So the regular supraventricular tachycardias are the AVNRT, AVRT, AT, jet and atrial flutter. Irregular are supraventricular tachycardias, atrial fibrillation, multiform atrial tachycardia, atrial flutter with variable conduction. So again, when we look at the regular tachycardias, we classify them into the RP, the short RP tachycardias, that is the RP interval is shorter than the PR, and then so the typical short RP tachycardias are the AVNRT and the AVRT, and the long RP tachycardias are the atrial tachycardia, sinus tachycardia and atypical AVNRT. So ultimately, when we are talking about all this RP, PR and all, just we have to understand what is the kind of activation that is happening. See, when we refer to the RP, for example, we are looking at an AVNRT, the re-entry is at the level of the AV node. So the fast pathway is taking the impulses back into the atrium, and the slow pathway is conducting antegrade. So what we are seeing here, typically in this thing is the P is actually is the retrograde thing. So that is conducting very fast. So as soon as the QRS has happened, almost you see that the P is depolarizing, that is the atria is getting activated. Now from there onwards the ventricle again has to go through the slow pathway, and that is why you have this RP-PR concept. So all these tachycardias you can explain on the basis of the activation pattern. So in the AVNRT you have a very short RP because the AV node is very near to these fast slow pathways. In the AVRT you have a slight delay. Again the retrograde channel is your axillary pathway, the antegrade channel is your His-Purkinje system. So you have a slight delay in terms of the onset of P. That is why they have classified the short RP into one thing less than 90 milliseconds and the other thing more than 90 milliseconds. Essentially it is a short RP tachycardia only. When you look at AT, ultimately it depends upon where the ectopic focus is firing from, whether it's firing from the left atrium, from the septum, whether some other focus. So if it is near to your to the His bundle, the PR will be short. If it is away from the His bundle, it will be long. So again we can correlate things like that. So in the atrial tachycardia, the AV node is not part of the circuit. The focus is firing from some part. So it reaches the AV node, so that usual AV delay will be there. So then you will have the so-called long RP tachycardia. The other is multiform atrial tachycardia. Again, multiple sparks are firing all along the atrium. Again, the AV delay would still be there because AV node is not part of it's not near the AV node. So that is how we do this. And then the flutter, the first thing is the flutter. We can see that this is a loop. This is a clockwise, this is a counterclockwise loop, the more common one. So around the cavo-tricuspid isthmus. So we see these multiple sawtooth patterns on that, and some of these flutter waves will pass on through the AV node to be conducted into the ventricle.